Over to you, Professor.
Thank you. Thank you so much for the nice introduction, Dr. Mukherjee, and the introduction also to Dr. Joshi. I'm, of course, very honored to have been invited to make a presentation for this very interesting venture of providing very high quality presentations for the whole world to share. And I'm also happy to see that we are 154 that are listening right now, which is really great. And so I'll share my presentation and we'll hope it will work as planned. Yes, it's working.
Yes, yes.
And everybody can hear me talking too?
Yes, it's okay for me. What do you say?
Great.
Suchita? Yeah, okay,
yes.
Yeah.
Yes, so I set out on trying to make an update on the recent evidence and what's left to learn. And I also watched some of the earlier presentations, and therefore actually I would like everybody to, if you haven't listened to this presentation by Professor Anup Katheria that was held last year, and Professor Katheria, who has been doing tremendous work in the research of core management and in other areas. He's presenting a very good and thorough presentation also on the physiology of the umbilical cord circulation. So I won't do a lot of that. So if you want more of the background information of physiology, please go back and watch this presentation by Professor Katheria. So yes, I'm from Sweden, which in this map is just in the middle and high up. We have still, well, we are going into spring now, but we had some snow a couple of weeks from now where I live. Further north in Sweden is absolutely snow yet. I live in or work in a university town called Lund in the very south of Sweden. And this is the university that is 350 years old, something like that now. And I started doing research in 2006 when I was 40 years old and a very busy clinician and father. So I'm really, by now I wonder how could I find time to starting doing research at that time, but that's what it is. And I've been interested in doing research on cord clamping the last 18 years. And as Dr. Mukherjee told you, my first study was research on umbilical cord clamping after 3 minutes in Sweden, where we could show a very significant reduction in iron deficiency in Swedish infants at 4 months of age. It almost went away, as you can see on these slides. And the delay cord clamping, there was no babies who had ferritin less than 20 at 4 months, and it was just 1 baby compared to 10 that had iron deficiency. And you can also look at the ferritin levels in this Swedish study, where it was 45% higher at 4 months. It's very comparable to the other 2 large studies that was made around the same time in Mexico. At 6 months, they had 45% higher iron stores. In Argentina, they actually had 59% higher iron stores, waiting 2 to 3 minutes. Mind you, it was this kind of waiting. And the study that was mentioned, and I will come back to, we could show that we had still after 8 months raise of ferritin, which is a good measurement of iron stores at 33%, still after 8 months. There it is. And for the Nepal study, we included well, actually it was 540 babies, but we followed up at 12 months, and we could see that there was an anemia reduction of 9% at 8 months, and with 8% in 12 months. This was significant. And in Nepal, where at that time it was 660,000 babies born every year, that would mean a reduction that about 60,000 children only in Nepal could avoid iron anemia at 1 year of age only by extending cord clamping to 3 minutes. We follow up also their development at 1 year of age with ASQ, and we could see that the children at risk of developmental delay, the ones that has less than 1 standard deviation below the normal, they were much fewer in the red. The red one is the delayed cord clamping. As you see, there were significantly fewer that were at risk of developmental delay only by doing delayed cord clamping. And also, as mentioned, we could also show improved scores in fine motor and social domains in Sweden. And it was in several different ways. We looked at the ASQ, and we could show that the fine motor function, the score was higher, the personal social score domain was higher, and in the strength and difficulties questionnaire, the children that had delayed cord clamping had a higher score. Even if it was just a little bit higher, it was still significant, but in the social subscale. And when it came to being below cutoff, there were fewer children in the delayed clamping group that had below cutoff. There were fewer in the delayed cord clamping group in ASQ fine motor and the movement ABC bicycle trail task. And that was for the study was constructed to measure for a whole group. But when we did a sub-study or did a division, we found out that it was actually in the boys that this effect was shown, that it was not at the same level of difference in the girls. And we could look back and see that girls, they had much better ferritin and iron stores already at birth, but that's beyond the scope of this presentation. So, and then we moved further to do this pilot study in Nepal, 2017. So it's 7 years ago. It was published 2019, where we were looking at randomized before birth, 1,560 children, and then we identified the ones that were needed support at birth according to the HBB protocol. So that could be suctioning, that could be stimulation, or it could be ventilation. Well, which is very important to see is that there was a lot of more babies that was decided to have intact, that was decided to need some sort of support in the intact cord resuscitation group. And I think that is something we have to be aware of in the future, because of course, if you can start doing resuscitation in the mother's bed, as we did here, it's easier to start that than if you have to decide to cut the cord and walk away with the baby, or even run away with the baby to another table. So there was a difference in how many children that was considered to have need of support. And of course, that means that the improved APGAR score, which was significant, as was the difference in saturation. That was might have been also because there was sort of not clear similarity between the groups. We tried to do that in different ways to change, and we couldn't. Well, it seems like there is actually an effect, but you have to read the paper to go to the depth of this. It's there are some methodological problems with this paper, absolutely. And as you see, there was not a significant difference, but close to for APGAR under 7. And for mortality, the 3 babies that died was all in the early cord clamping group. There was no children that died in the delayed or intact cord resuscitation group, but that was not a significant difference. So when I set out to make this presentation, I think it was a week ago, I did this search string of cord and clamp or cut or milk and umbilical, and then also placental transfusion. And for the years of 2022 to 2024, there is actually 325 studies published. And when you look through them, I think it ended up with 278 studies, if I remember right, that was actually about cord clamping or cutting or milking, published just these few years. And you can see on this graph that the interest of doing research on cord clamping has really been rising for the couple of for the last two decades. So I'm happy to having started 2006 to be in the group that has been following this for quite a long. There are some people like Judy Mercer, Heike Rabe, that has been doing research for longer than that. But it's very evident when you start looking at these papers that we have some problems with cord management, because it's different if we talk about preterms and terms. We have to think about, is there a difference between vaginal and cesarean births? If the baby is vigorous or stable, or if it's hypoxic or unstable or having apnea, depending on also, of course, if it's term or preterm. Then we have the concept that I want to introduce about the sustained cord circulation, because I don't really think that we should talk about delayed cord clamping or physiological cord clamping, because what we actually do is that we sustain the cord circulation that has actually been going on for at least 22 weeks or sometimes 30 to 42 weeks. For as long as the fetus has been there has been a cord circulation, and we will just sustain it for a couple of minutes longer. Then we have milking, and then there is the discussion of when to clamp, if it's on these different timings, or if we should call it physiologic. And then also mentioned by Dr. Joshi, the twins and the jaundice. So there is a lot of questions, and actually some of the papers that has been published the last years, they meet up to try to answer some of these questions. And in the sake of timing and keeping the listeners or the watchers of this presentation concentrated, I had to concentrate on the ones that I personally think are the most important. There are other studies that I would really be happy to also present, but in my preparations, I had to cut very hard, and I hope that we will have opportunities to have other of these last studies presented in other further on. Anyway, so perhaps one of the most important papers was published in November 2023 in Lancet, and that was a systematic review and individual participant data meta-analysis with a lot of co-authors, and perhaps there is some listening now, including, as I know, the host himself. Anyway, that was a systematic review or meta-analysis where they gathered 6 studies, 48 trials, 6,367 infants. And they compared deferred cord clamping, as they chose to call it, 3,260 babies compared to immediate cord clamping. That was one part of the study. And the results there was that the delayed cord clamping, there is an odds ratio of 0.68, as you can see below here, compared to immediate cord clamping in death. So there is a reduction with 32%, almost 1/3 reduction in death during admission. And if you compared cord milking to early cord clamping, there was almost the same odds ratio, a little bit higher, but this was not significant, as these diamonds down here, they crossed the one line. So even if there was a trend, or what you would call it, for also being positive for milking, that was not established in this study. They could see that there was also an effect of need of blood transfusion, but actually otherwise for secondary outcomes like intraventricular hemorrhage, chronic lung disease, hypothermia, there was a little bit higher risk if you were delayed clamp, but either on sepsis, NEC, or PAD, patent ductus arteriosus, there was no significant effects on any of the major morbidities. Still, there was this very significant effect on death or morbidity. At the same time, with the same material of individual participant data, the researchers that I should have said that this is a very good team, mostly located in Australia, Sydney, led by Anna-Lena Seidler and Lisa M. Askey. And in this study, they had almost the same amount of infants, 6,094, and they wanted to see if there was any difference in short, medium, or long deferral of cord clamping or intact cord milking. And in this, they had all these kind of different trials. There were 8 trials comparing milking with immediate cord clamping, 6 trials comparing milking with medium deferral. So they had this network analysis that they could use their very advanced, I suppose, statistical analysis to show that when you look at these numbers, that was actually the long deferral. If you waited more than 2 minutes to clamp the cord, that you could see a significant effect on death. And that was very significant, that you can see that it was 0.31, that if you, in these studies, waited more than 2 minutes, you would lessen the morbidity with 69%, which seems, even for me, almost improbable. But the problem perhaps is that, or the critique, which also is in the paper as a limitation, is that it's only one, and here is 3, and here's 1 trial that actually included infants with a long deferral. As you see, 70, 469, and 40 babies. So it was quite a few of the babies that was included that had long deferrals. So this was not referred as significant, or well, even if it was a significant finding, there was still some humble discussion around if this is if we could trust this data or not. But for the people that are afraid of waiting longer, it's more that it's tending to be more positive than less positive to wait longer. I think you can use the data like that. Almost the same week, I think it was the week after, Anupkatheria, they published a follow-up of their earlier study. The original study was published in JAMA, and now they looked at the subset of the infants at 28 to 32 weeks. I'll go a little bit into detail. The original study, I think many of you have heard about. They compared delayed cord clamping with umbilical cord milking, and this study had to be closed before they reached the full amount of patients, because there was a difference in babies having severe ventricular hemorrhage in babies born between 23 weeks and 0 days and 27 weeks and 6 days. as you can see here in the milking group, it was 22% that had IVH, and it was only 6% in the delayed cord clamping group, and this was really significant. And that made a risk ratio of 3.8. So it was 4 times higher risk to have an IVH when the baby was milked compared to delayed cord clamping in less than 28 weeks. And in the new study, the authors, they looked more in detail, or they continued to include babies further on. So they got a larger material of babies. So in the end, they had a little bit more than 1,000 babies included between 28 and 32 weeks. And in this study, they could not see any difference in severe IVH. It was 2 in the umbilical cord milking group, and it was 4 in the delayed cord clamping group. And here they could show that there was no differences. And the limitation here was then that there were very few severe events. As the people who are clinicians most certainly know, it's much more. There is less IVH in infants after 28 weeks. So perhaps this is not such an important finding in itself, but reassuring in one sense that milking is not hurting, doesn't seem to be hurting babies in the short run when doing in babies over 28 weeks. And as like a continuation of that, but published earlier, was the MINVI trial, also made by Anopkatheria. It was published in the year earlier. And here they also, in this multi-center trial, they included a lot of infants, 1,730 infants, compared umbilical cord milking with early cord clamping, and looked at admission to the neonatal intensive care. And this is a nice picture from this paper where they summarize the findings. And as you see, there was a reduced NICU admission, 23 compared to 28%. They showed a higher hemoglobin in the milked group. There was almost, there was a reduction of hypoxic ischemic encephalopathy, IEH. I hope it is now HIE. And also there was less need of therapeutic hypothermia. There was less need of respiratory support. The APGAR score was reduced. There was fewer babies that have lower APGAR score in the milked group. And there was just a little bit high, there was a little bit higher bilirubin in the milk group, but there was no difference in the need of phototherapy. So this MINVI trial really showed some very positive results in performing milking of the umbilical cord 4 times compared to early cord clamping. And I think they are doing sub-analysis to present further on, and they will also do a follow-up for these babies. And yes, but which you could discuss a lot. You have to think about the milking. For me, myself, especially in a baby that is hypoxic and have a heart that is not pounding or contracting as strongly as usual. If you will do a milking, you will put in about 2 teaspoons per kilo, or tablespoons, 2 tablespoons per kilo, about 25 to 30 milliliter of blood into a heart that is as large as the baby's fist. And it's a little bit, even if this is not proven very nicely but still, on the other hand, it's shown to be harmful in babies under 28 weeks, and it's not shown to be harmful for babies over 28 weeks. I still wonder if it's a good thing to push in about 2 tablespoons of blood into a baby's heart and body without it being prepared to pump it further on. But and that's why we and several others look at intercord resuscitation. And here it is, of course, more that you think that you can have the transfusion of the placenta, that will give you this larger blood volume, but you will also have, for a couple of minutes, if the heart is pounding or contracting, you will have a continued placental circulation as long as the placenta is still at the uterine wall, and if you have a circulation. There is a possibility for the baby to have a respiration through its placenta to continue for a couple of months and a couple of minutes. That would, of course, correct the metabolic situation, and in the theory, then improve vitality, give higher Apgar score, etc. And this was studied in children over 32 weeks by Badruddin and et al. A lot of very significant researchers in Sydney and in especially Melbourne, where the baby duck trial, they included 123 infants where the pediatrician was called to attend. So that was when the obstetricians thought that there was a baby that they were expecting to not be vital when it was born. So the baby, they were randomized to either physiological based cord clamping and positive pressure ventilation or early cord clamping. And the outcome was mean heart rate between 60 and 120 seconds after birth. And I hope that I don't think the sound will work, but just to see how they performed it, they had this table with what they needed for their resuscitation, and then the pediatrician was wearing a sterile gown and sterile equipment. They put a mattress on the mother's legs and prepared. They even had the neopuff and the mask there sterile. And then they put the baby in the lap of the mother and could make resuscitation measures like this. And at the same time, they filmed the monitor, so they could, and also had the sound on, so they could see what was going on. And then they could give you respiratory support. And here you see that the obstetrician had to move away a little bit, but people could still, just keeping the baby on the mother's lap, have quite some space to start doing the resuscitation. So actually, they couldn't see any difference at all in time to first cry, APGAR, or need of respiratory support. It was quite disappointing that being able to support the babies directly after birth in the lap of the mother, there was no significant differences, except that there were more babies that received positive pressure ventilation. So it was 48%. If the baby was still in the lap of the mother, there was 48% that got positive pressure ventilation compared to only 25% in the group that was cut early. And the respiratory support was initiated sooner. So this is a little bit similar to our Nepal findings, that when you're close to the mother and you don't have to cut the cord, it seems like there is, by some reason, a tendency to give more support, to be more active. There is then this very important, I think, study came out from India regarding resuscitation with intercord versus clamped cord in late preterm and term neonates. And you might say that this is almost like a a combination of the study we did in Nepal and the baby duck trial, because in this study, both vaginal and cesarean births were included. So, and it is a large amount, 400 needles over 34 weeks. And there was, in the end, 71 that needed intact cord resuscitation, and there were 91 that had early cord clamping and resuscitation. So the numbers ended up to be quite similar to the Nepal study and a little larger than the baby duck study. And the outcome was an expanded APGAR score at 5 minutes. And this APGAR score is a score that is suggested by also of the American Academy of Pediatrics to involve also more advanced measures if you need that or not. So this is a lot of text, but the expanded score includes the following interventions that if you don't do it, you will have 2 points. So it's oxygen, CPAP, power positive ventilation, intubation if you give surfactant, chest compressions, and medications. So 1 point is added for each of these interventions not administered. So you can get a possible score of 17 instead of 10. And the extended APGAR score in this study, the Rhina study, was higher in the intact cord resuscitation group. But still, it's just the difference of 1, 15 or 14. But that said, that it's not a large difference. There is difference. There is still a difference. And I think that we should really take impressions of this study, as there was not any negative findings. And as in Nepal, there was a higher oxygen saturation. As you see here, 89 compared to 85%, which was significant. And there was fewer babies, even if it was not significant, there were fewer babies that needed positive pressure ventilation. And so this was a study that was in the same results as in the Nepal study, and was made with a trolley, which I should mention. And there was also higher APGAR score and oxygen saturation, as I told you here at 10 minutes. The APGAR score itself was higher. The heart rate was a little bit lower. The oxygen saturation was higher. So there was some very nice results and no safety concerns. That is still perhaps the most important thing to stress, that doing this doesn't, you don't have to think that it must be any danger for the baby starting this intervention. Then this study hasn't been published yet, but it was long awaited, the ABC3 trial from Holland. So these are pictures from the Ronnie Knoll, who is the primary investigator, with his senior Ariane de Paz as a last author. They did a trial on preterms under 30 weeks. And this is pictures with my camera from this. So this is not published data. So you can't see that these are they are only preliminary. And this you can see it's under 30 weeks, and it's physiologically based cord clamping or standard care. And then they were looking at survival without major cerebral injury or without necrotizing enterocolitis. And this is still just preliminary data. This is how the cord clamping was performed and for how long. And this is the baseline where they were comparable, the groups. And in this preliminary data, you could show that there was a start of respiratory support earlier, and the cord clamping was much later. It was after 5 minutes compared to less than 1 minute in the standard group. And also in this preliminary data, you couldn't see any significant difference in the primary outcome. Even if the odds ratio was 0.05, there was a large overlap to over 1. And as in this preliminary data, they could show that if there was an effect, it seemed to be mostly on the necrotizing enterocolitis, not on the death or cerebral damage. But this is still preliminary data, and we look so much forward to see the published data. And also in this preliminary data, there seemed to be an effect that was significant in male infants, that in the primary outcome, there was positive effects in the male infants. So that's for the studies. Then I have to mention 2 studies that we have published. Both of these are in open access papers. And that is one where we compare, this is observational trials. And we wanted to look at the cord clamping in Sweden today, and to see about the bilirubin and the jaundice for term infants. And in the first study here, there were 904 term vaginally born babies in 2 cities in Sweden. We had a mean cord clamping time in this observational trial of 6 minutes, which seems to be the normal in Sweden today. And there was no correlation between cord clamping time and bilirubin level. It was the similar, there was no, even if there was a difference in cord clamping from almost immediate to 20 minutes, there was no correlation between CC time and bilirubin. And the same, we did a follow-up because we really wanted to see if that could be right with a medium of 6 minutes for cord clamping. And we had looked at 558 term vaginally born children in another large delivery department in Sweden. We had 1,330 bilirubin measurements, and still no difference, no correlation between cord clamping time and bilirubin level. The same was in the original 392 infants that we looked at. So from the Swedish data, now on about 2,000 babies that were term, there was no correlation at all between cord clamping time and bilirubin level. And we also published this autumn a scoping review that I think could be helpful to look out and look a little bit further on. We did a scoping review or a systematic literature review on all the studies that has been doing resuscitation with intact cord circulation after cesarean section. So we were looking at the bedding or the platform, and there was the similar results and very heterogeneous if you were decided to make the resuscitation on a platform or at the mother's lap. Position of staff, almost all do like this, and as you could see in the video by Badruddin, that the staff come up, the neonatal staff come up quite close to the mother from one side. Sterility and aseptic management hasn't been that problem. In most studies, the neonatologist is in a sterile gown and have sterile gloves. Sometimes a NICU nurse, sometimes not. And then you usually treat the head and the arms of the baby as non-sterile, but you try to not touch the lower part. So you try to think of that as sterile. And as for temperature control, there was some studies pointing that there might be a little bit colder baby when you do intact cord resuscitation, but there was no differences that was very significant. Then, as also mentioned, I'm doing, or we are performing in Sweden, a continuation of the study we did in Nepal in doing intact cord resuscitation in the mother's bed like this. And when we chose how or where to do the resuscitation, it was very important for me after my experience from Kathmandu to try to show that it is possible to do with simple equipment, not needing a trolley. but it is possible to do it in the mother's bed, because if you want it to be possible to implement in countries in Africa or in countries that the countries with lowest incomes today, I think that we need to look at the methods that are implemented with fewer sources, and where you don't have to go and fetch a trolley either. So this is but we use the NeoPuff, which wouldn't be available in low-income countries. And we compare children where we at least wait 3 minutes with resuscitation compared to early cord clamping. And we look at APGAR and admission to NICU and neurodevelopment. And we want to look at 600 babies that get a resuscitation. In Raina, I think it was 150, and it's almost 200 in our Nepal study. So this is a much larger study. And today, as we speak, we have resuscitated 504 babies, and we hope to end this study in the autumn, finally. And so this is what they bring into the delivery ward in the babies that are randomized. They have a sort of a stand like this, where there is a NeoPuff. There is not everything on it, because there should be a NeoPuff, suction equipment, a gas blender, an APGAR watch, and then possibilities to take pulse oximetry or ECG. Quite simple equipment, which you can bring in or keep on the delivery room without disturbing so much the delivery itself. And we are looking also at neonatal outcomes and development further on. And we are also very interested in breastfeeding, parental bonding. We do a lot of qualitative studies on staff and parents, because we want to do this as a structured implementation research that could be used if you want to use it in other places further on. So with that, I would like to end my presentation by acknowledging my old friends and colleagues in Nepal, especially Dr. Aziz KC and Nisha Rana, and the SAVE team, and the upcoming Success trial group for the study we are planning further on. And I'll stop sharing. Yes.
Thank you, Professor Ola Andersson, for such an amazing lecture. Before we go on to the panel discussion, here is a 59 seconds promo video for the upcoming national conference of the National Neonatology Forum India. So friends, without wasting any more time, let's go on to the question answer session. To moderate the panel discussion, I once again invite the moderators, Dr. Suchita Joshi and Dr. Tanushri Mukherjee. Over to you, both of you.
Thank you. Thank you so much, Professor Ola, for this wonderful presentation. And, you covered so many studies from the early on, even the Indian studies that has been done. And so I would like to ask with Dr. Prakash Manikot's question that what he has seen, that how does the routine administration of uterotonic drugs in that following the delayed cord clamping affect the practice, be it in the normal delivery or the cesarean delivery?
So there was a very nice Argentine study performed by Professor Vain that was published a couple of years ago, which I could have chosen to put in, where there was no difference in the outcome of the baby if you gave oxytocin before or after clamping. And in Sweden, when we have delayed cord clamping, we did it after the 3 minutes. So in this randomized control trial in Sweden, which was my first study, we published a separate paper on this, where the oxytocin was given after clamping, so after 3 minutes, and there was no difference in postpartum hemorrhage. In one of the observational trials now, where we had this median of 6 minutes of cord clamping, they give the oxytocin earlier, and actually there was a trend, or even a significant result. There was less bleeding, postpartum or maternal bleeding, if you clamped the longer you waited to clamp, there was less postpartum hemorrhage. And the interesting thing is that there is an old Cochrane review when you did early cord clamping, and where they compared after early cord clamping, if you opened the clamp and emptied the placenta out into a bin, or if you just kept the clamp, and there was also then less hemorrhage if you emptied the placenta. And of course, that there is some sense in that if the placenta is emptied, if there is less blood, it will be easier for it to let its grip from the uterus and come out, I suppose. But so I think that there is at least in some physiology in having the placenta empty its blood. And then for the oxytocin and the contractions, we still don't know what the forces are of the transfusion, and that is a 1-hour lecture with more questions than answers. What we still don't discuss is the opening of all the vessels in the skin and in the muscles of the newborn when it's born, especially after vaginal birth. It has this catecholamine stress, and it will have contracted vessels in the muscles and in the skin that will open up after a couple of minutes. So yeah, well, to shorten up my answer here again, it doesn't seem that there is any large difference between if giving oxytocin before or after clamping.
Thank you. So, Professor, what is your optimal time, the consensus of your cord clamping? So what do you suggest?
As you might have realized, we have a very strong and independent and very well-educated collective of midwives in Sweden, and they are the ones that handle normal births. The obstetrician is not involved in normal deliveries or normal births. And after the original study, we changed the recommendations to 3 minutes in Sweden, but still, when we did our observational trial studies now, we realized that they actually wait in a median 6 minutes, and we couldn't see any differences. And for the term baby, where you have a strong heart and the baby is, vigorous, I think the babies can quite well handle the transition itself. And then we have the recommendation in Sweden today to clamp the cord when the placenta is delivered, because after that the placenta is a dying organ. It's hypoxic. So after that we discourage. And for preterms, I think there is some very nice physiological studies by the Dutch and in Melbourne, and now coming in other places, that also the preterm seems to be able to handle its circulation also after birth, as it has been doing. It has been doing, it has been controlling its blood pressure and circulation by itself for a lot of time intrauterine. So for the vital preterm, physiological cord clamping seems safe. But when it comes to the hypoxic infants, either by being, having a surfactant deficiency or having had a hypoxia, intrauterine hypoxia, where the reflexes of the baby, the central reflexes or the heart is not working, it's much harder to say. There we need more studies still to know what is the optimal time.
Sure, sure. So another question from Dr. Livert Flores, that what about in RH incompatibilities and HIV infection? So how to go about it?
So the RH incompatibility, the baby, there will be, with delayed cord clamping, there will be a higher amount of immunoglobulin. The general immunoglobulin will be higher. We have studied that too. As you get a larger amount of blood, you will also get a higher amount of immunoglobulin. But the studies that has looked at the RH incompatibility couldn't see a large difference in jaundice, but less need of blood transfusion if you did delayed cord clamping. So there is actually more of an effect, positive effect, while waiting to delay the cord clamping, because there is less need of, even if you have an immunization and you will have a hemolysis of your blood, there will still be less need of transfusions if you delayed the cord. And as for the HIV, the connection with the mother and the mother's blood has been there through the whole pregnancy. So it's a little bit hard for me to understand why a few minutes more of being connected to the placenta would be much of a risk. As long as the mother is not bleeding, of course, that would be perhaps a higher risk. But also the studies, there is, as I remember, a few studies that hasn't shown any difference in the risk of contracting HIV. And that was, I think, what we can see about COVID too, that there was no problem. We did a systematic review on the timing of cord clamping when we had the COVID pandemic. And in the beginning, a lot of people chose to do early cord clamping because they were afraid of vertical transmission. And I have done 2 systematic reviews on this, and you couldn't see any higher risk of vertical transmission with delayed cord clamping. And of course, I think it's the same. You have been connected to the mother in the womb for so long, so we couldn't see any higher risk of transmitting the virus.
Thanks, Dr.
You have to tell me to give shorter answers if you think I talk too lot.
No, it's absolutely okay. Absolutely. So, Dr. Suchita, we will take the next questions.
Yeah, sure. Thank you. Thank you, Tanushri. First of all, I would like to thank Dr. Andersson for this delightful talk. And I feel really privileged to listen to these all groundbreaking studies done in my country, Nepal. Thank you, Dr. Andersson. And the next question we have is from Dr. Pradeep, who is asking whether delayed cord clamping should be done in twins. And he also has a second question saying whether delayed cord clamping should be done in babies with fetal growth retardation. So Dr. Pradeep has 2 questions for you.
So so the last was fetal growth restriction. What was the first category?
Was in twins.
In twins, yes. So in dikaryotic twins, the data now says that it's possible because it seems that there is no it would be the same effects in dikaryotic twins. So we have that recommendation in Sweden. I think we also did that in Europe. In monokaryotic twins, I think that the problem is that there are so many different scenarios of how the blood can be transfused from one twin to another. So we are still don't have a good answer for that. And I think that it will end up that there has to be a sort of individual, you have to make that decision from each case and try to watch the baby and perhaps have been speaking to the parents and colleagues before to have a plan on what to do and try to find out to see if the baby, what kind of state the baby is. But I still believe, and that would be my answer for the fetal growth restriction also, babies, are that we have a tendency to forget that the baby has been handling its hemostasis intrauterine for a long time. And as long as the baby is vital and can control its blood pressure and its heart rate and the cardiac output, as long as the baby is vital and we don't try to help the baby by keeping it much lower than the womb or by milking, but just waiting to have the baby start breathing and going through the transition, it will choose itself how much blood that it is prepared to admit into its body, because I don't think that it should be the full transfusion in all babies. But now I think this is not based on any research, but more from a physiological understanding that we have to start to think of the baby as a quite capable individual that has been controlling its blood its blood volume very well for a lot of time. So if we don't try to think that we are smarter than the baby, I think the baby will help us to decide.
Okay. Dr. Andersson, I'd just like to ask a question myself. In terms of fetal growth retardation, would you be worried about polycythemia and related complications in these babies with prolonged differing in cord clamping?
So there is the polycythemia is, as you say, when you have a fetal growth restriction, there is already a higher polycythemia because the baby has been trying to compensate for the not as well working the placenta. And of course, there is, you might expect that the delayed cord clamping would give the baby a polycythemia that would be symptomatic. As I think you know that there has been no studies showing that delayed cord clamping give a symptomatic polycythemia. And the studies that has been published, there is at least one from South Africa. I think I have seen some more, but at least one from South Africa where they looked at low birth infants for weight SGA babies, and they couldn't see that there was any negative amounts. And back again, if you would ask if you would do milking or if you would put this fetal growth restriction baby quite a lot of below the mother's womb and weight, then perhaps when the baby couldn't control its blood volume itself, I think there is a risk. Okay. But if you let the baby decide, then I think the baby will be able to control what it is capable of handle. But that's perhaps me being a little bit optimistic. I don't know.
Okay, thank you, Professor, for that. So the next two questions I have are very similar, so I'll lump them together. And they're both about whether the cord should be clamped once the placenta starts getting detached.
Yeah, I really believe that. And there is a couple of reasons. I said one before is that the placenta is when it's detached, when it's not still on the uterine wall, even if the baby is starting breathing, the placenta starts to die. And we haven't studied what's happening when the placenta is asphyctic, but of course that will be that the blood there will be less oxygenated, and if people here, the ones that has been putting in umbilical catheters, most of you have realized is that the artery is quite strong and will be closed, but the umbilical vein, it's a quite loose structure, and I don't trust the umbilical vein to be patent in children or in newborns, even after 30 minutes or after that, because I really have tried to look through the literature, and I can't find any anatomical really structure or a place or possible where it really closes the umbilical vein. The arteries, they close by themselves. It's like the ductus, they have very strong walls. But the umbilical vein, and it's shown by ultrasound that while it's open, when the baby screams, there could be a flow from the baby back to the placenta, retrograde flow. So, and we have some reports. One report is from Sweden. There is a case report published from another hospital where they waited to clamp the cord for 50 minutes. And the baby had a hemoglobin of 180 in the umbilical cord directly after birth, but at 50 minutes unclamped, it suddenly came into shock. It went pale, and it had a high heart rate and get trouble breathing. And they had to take the baby into the NICU. And if I remember right, the hemoglobin was 78 or very low. And they tried to find a source or where, they looked at the brain by ultrasound and the liver, the baby's body. They couldn't find the blood inside the baby's body. Unfortunately, the placenta wasn't possible to recover, but there was a high probability that there was a retrograde bleeding when you waited to clamp by that long. So I think that should really, that's my answer.
Thank you. I'm sure that clarifies the question very well. The next question is about whether the babies who are born by cesarean section, and if the mother is under general anesthesia, would you recommend delayed cord clamping?
So we have been doing some literature studies in that, and I really think that we are preparing actually a paper. I don't know when we will finish it, but we could start to have discussions with the anesthesiologists on what drugs to use when you have general anesthesia, because we haven't had that discussion with them before. Well, I haven't had, but I started it now, because of course you could think about blending. I've seen some studies where you blend in ketamine that is not as breathing suppressant, because that is the problem. If you wait to clamp, if you have an intact cord circulation and you wait to clamp the cord, the baby will be anesthetized and will not be breathing by itself. So of course, we as neonatologists or all staff taking care of newborn babies, it's so important with the breathing more than anything else. We want the baby to breathe, and of course, if there is a baby born by general anesthesia, we could look at the heart rate, try to keep that, and just starting doing resuscitation or giving ventilation until the baby starts to move by itself after the cord is cut. But I think that is very difficult for us to accept. So for now, we say that in cesarean sections, we recommend the cord clamping at 1 minute, because it also seems that you will have quite a large amount of the transfusion at that time.
So the next question is quite interesting, and I've often wondered about it myself. The question is, the obstetricians are very keen to lift the baby with cord attached to show it to the mom. What is your opinion on this practice?
Yeah, no, that's really nicely shown that if you lift the baby and you cut it when it's lifted, there will be less blood. The transfusion will be less. So if you do that, you can lift the baby, show it to the mother, but then you should put it on the lap or on the chest of the mother and let the baby breathe and adjust its blood volume, as I said before, for a minute or two. to compensate for this lifting, because I don't think for a term baby that I don't think there is any risks with that. But if you want to optimize the baby's physiology, if you lift it to show it to the mother, then put it on the chest or the lap and let the baby establish its transition by itself for a short while.
Sure. I think Dr. Tanushri Mukherjee would like to comment on this as well, if I'm correct.
Yeah, it's true. It's very common in your, and that time sometimes it's endless. So I'll just carry on with the next question. So, that study that this is done by Dr. Vimal, and he said, "Thank you, sir, for the excellent presentation. In cesarean delivery, Dr. Anup Katharia group has showed that the intact cord milking is better than DCC, both in blood transfusion and also in the long-term language and the cognitive outcome. So what is your take on that?"
Yeah, well, my take on that is always the timing of the cord. So because I would absolutely, I can't disagree on that. There was positive effects, and I think the long term is really interesting there, because we don't know what is the perfect hemoglobin or the perfect transfusion in cesarean sections. But I think that there is. I think that if you could optimize the timing of the delayed cord clamping in cesarean sections for the baby to really have the right amount of placental transfusion, which we don't know when it is, I would believe that we would have comparable results with the milking group. But for term infants, as it is right now, if you look at the data, milking seems to be safe. And some data even say that it could be more positive than at least clamping for 30 seconds or 1 minute. But still, as I said, you can look at your fist or a baby's fist. That's the size of the baby's heart, and then you put 2 tablespoons for every kilo, and then you look at the amount of blood that is, and that you will push that into the baby, and expect the baby to handle that. And that's my only answer. I think that if the baby is vital and can breathe, and it will take care of it by itself. We should, but I'm really happy that Anup Katharia is doing all these studies, and because we really need to learn what is the best for the babies. So the longer we do these studies, we will do it in more and more specialized cases. The complicated thing is that in all the guidelines nowadays, they want to make it simple. They like in American Academy of Pediatrics, they say 30 to 60 seconds or more. In the ILCOR, it is 60 seconds or more, and that's the WHO too. And I'm really concerned because all the data in term infants that has shown positive effects are on babies that are at 3 minutes or more. Except for one study, and that's a very important study in Mexico, where they had 2 minutes. But there is no data on any positive effects between 1 and 2 minutes, as it is after. We did all our studies after 3 minutes. So when people talk about delayed cord clamping at 1 minute, it's not. I think we have to understand that for term infants, that's not any delayed cord clamping that has shown any positive effects.
Just another. Like that is my question, that the cord milking that increase the transfer of your stem cells rather than the delayed cord clamping. So how to explain this?
Yeah, so if I remember it right, they found that it was a higher amount of mesenchymal stem cells that was in umbilical cord milking, and there was a theory that it might be by the physical pressure you might get higher amount of mesenchymal stem cells just by the force of doing the milking. But also here I wonder if you would wait a longer time, would there be a different concentration of different stem cells in the placental transfusion going over to baby? We don't know that. What is really interesting, and I don't know if you know that, but after delivery, there is higher amount of stem cells in vaginal births than in cesarean births. So when you do these studies to see if how many stem cells you can get for banking, you see that you will have a larger volume of blood when you do cesarean sections, but you will have less concentration of stem cells. And that's, I suppose, it's the physiological stress. And then when if you check the stem cells circulating in the baby, I think it's after 2 hours, it's gone. From being the concentration is the same in a newborn in the blood. When the baby is born vaginally, if you look at the concentration of stem cells, it's the same as we have in our bone marrow. So it's very high just at birth, but it drops very fast. And so there is a dynamic here that's very hard to understand. So yes, they have shown that, but that's also open for looking at in different timings when you do delay cord clamping. I'm
Sure.
sorry, I really like to talk about it, but you have to forgive me. We're talking a lot.
Sure, sir. Sure. So Dr. Abdul has asked, what is the difference between DCC of your suggestion one, WHO guidelines, and NRP?
Yeah.
So
in NRP, I think they have the same as the American guideline, 30 to 60 seconds or more. And WHO, their recommendation, I think it's actually from 2014. It's 60 seconds or more. But they say in that if you know how to, if the baby is not breathing by itself, if you know how to provide positive pressure ventilation, you can wait longer than that. And that's in Sweden, we have divided the cord clamping times in different cases. So for healthy term vaginally born newborn, that's the common one. We recommend cord clamping when the placenta is delivered now in Sweden. And for almost all other cases, we say 1 minute. But that was before this very interesting findings by Seidler, that it seems like perhaps if you wait even longer, that you could have some positive effects. But now we are awaiting the publication of the ABC3 study from Netherlands that I showed some preliminary data from, and also the data from the American study called Vent First on preterms that was made in a similar way, and where they also are expected to be published this year.
okay. Dr. Suchita, you will carry forward.
So I could add that.
So sorry,
Yeah.
sorry. Can you hear me now?
Yeah.
Okay. Then the next question we have is about low-lying placenta and placenta previa. Would you suggest deferred cord clamping in these situations?
No, I'm sorry, I didn't understand the expressions here. What did you call the placenta?
Placenta previa or low-lying placentas.
Oh, yes. So if the baby is born, so that's a decision, an obstetrician decision, if you can deliver the baby through the vaginal route or not, I suppose. So the clamp, from what I understand, I would say that if it's a low placenta, the interesting thing is if it's difficult to have a vaginal birth, because when the baby is born, it's more about if it's born vaginally or not. So that's the low position placenta. And what was the other part?
I suppose it's a similar question. placenta
Yeah.
previa. So it's also abnormal position.
Yeah, placenta previa. Yes. So no, absolutely. I suppose I won't get into any discussion on what way to deliver babies, even but when they are delivered at vaginally birth, I expect that the what we call the diving reflex in Sweden at least, and you know, the stress of contracting your muscles and skin to centralize your blood circulation to your heart and brain, which happens in all vaginal births. That stress is higher when you're born vaginally, and that makes the transition a little bit slower to have a full blood amount when you are born vaginally. So I think we will find out that the cord clamping time has to be a little bit longer in general for vaginal births than for cesarean births, especially for elective cesarean births where the baby hasn't been stressed at all and might be faster in opening up all its vessels and deciding again by itself how much blood that it wants or needs.
You've already talked in great detail about the stem cell transfusion, but our next question is about delayed cord clamping or intact cord milking. Which one is associated with greater stem cell transfusion?
So there is only a very few studies that has looked on that, and most of these studies are people that want to analyze the content of the blood because they want to make stem cell banking. So then they have looked on differences in this, and as was mentioned, it seems like that there is a higher amount of, which also Anna Katheria has shown, that there is a higher amount of mesenchymal stem cells in the blood after milking. But I don't remember the timing of cord clamping at that time. So it's still that we have so many different situations. There is a different concentration of stem cells if you're born vaginally or if you're born by cesarean. There would be difference in the stem cell concentration if you are born and have an asphyxia or not. So again, I would say that there is too many different variants here to say one answer.
Sure. So the next question is about how long to delay the cord clamping for 1 or 2 minutes. But I believe you have made your point that even 6 minutes is a norm now in Sweden. So am I correct?
Yeah. So I really want to stress that all the data that has shown positive effects on term infants are that has been randomized trials that has shown long-term effects has been looking at 3 minutes or more in the trials. In the Nepal study, where we had 540 babies, where we showed less anemia at 8 and 12 months, we compared 1 minute to over 3 minutes. And the median time for cord clamping in the early clamped was still 30 or 35 seconds, something like that. But the group was up to 1 minute. And that was compared to over 3 minutes. So the data itself speaks for term infants that you should wait more than 3 minutes. And I'm surprised that people writing guidelines don't recognize this more when they do the recommendations.
Hopefully we are all more, enthusiastic about cord clamping after today's lecture, definitely. And
We hope
more
so.
convinced, we're more convinced ever than before. So the next question is about what would be the ideal position of the baby for deferred cord clamping?
The ideal?
Position of the baby.
Oh, yes. So the ideal position would be, I wrote a paper with Judy Mercer, who has been writing quite a lot about cord clamping for many years more than me, and I think she's 80 years plus now, and she has this also theory now that the well-being of the infant just after birth, because there has been very nice studies showing that skin to skin also there is a less mortality if you allow immediate skin to skin. There was a very nice study from the WHO initiative published 2 years ago, I think, in the New England Journal of Medicine, where they showed a similar reduction in mortality by providing 15 hours of skin to skin per day, directly after birth. And I know there is studies now that are combining umbilical cord clamping and immediate skin to skin. So you put the baby skin to skin, and you wait to clamp the cord. And if the mother is half sitting or lying down, we know that if the baby is allowed to wait to clamp the cord for 3 to 5 minutes, the transfusion will happen also then against the gravity when the heart is strong, because I really think that's an important thing. So for a healthy preterm, I would say that and that really comes to all babies all around the world, to put the baby on the mother's belly, and or for term baby, pull it on the mother's abdomen, skin to skin, and wait to clamp the cord at least 3 minutes. That's the data for what we can trust today.
Okay, thank you, sir. That's very clear. And our last question for the day, I think, is what is the difference between placental transfusion and placental perfusion? Are they one and same?
Dr. Suchita, and I also have a question. So,
okay.
Permit, maybe after you.
Yeah.
Yeah,
I'm not in a
sure.
hurry. So no, so the circulation, the placental perfusion or circulation, it's really interesting that you can. There is. I'm really happy to say that it was made at my hospital, but before I started working there, they compared that made serial blood gases on the same umbilical cord after directly 45 seconds, 90 seconds, and 135 seconds, up to 2 minutes after. And still after 90 seconds, you can see a difference in the carbon dioxide and in the oxygen content. So you can see that even after 1.5 minutes, clearly the placenta is still making the blood oxygenated and help the carbon dioxide go away. In term infants, you can really see that on the blood gases. After 1.5 minutes, 90 seconds, it started to be very difficult to take arterial samples, because then the umbilical artery closes. And then we think that after this circulation is perhaps diminished in the arteries, there is still more blood transfused. And people have been trying to look at this by ultrasound and by doing experimental studies. But what is difficult to appreciate is the amount of blood that is passing the whole for every minute. I don't remember what the cardiac output is for a newborn, but it's 30% of the cardiac output at the term newborn goes to the placenta. So even if it goes out like 40 milliliters a minute, and it goes in 42, it would be very hard to see by doing live recordings. But the difference is that the net transfusion, the difference of how much blood is in the placenta if you cut directly or if you wait 5 minutes, is 25 to 30 milliliters per kilo. That makes 2 tablespoons per kilo.
Okay, thank you very much, Professor Andersson, for answering these questions very patiently. I'll hand over to Dr. Manoj.
Thank you.
Professor Andersson, before we close, can I also ask you a question?
Oh, I'm in no hurry, so just also carry on.
Last year, we found some new. I mean, you mentioned so many papers. Actually, one of the papers published by the German group, Benjamin Cohen group, was talking about extrauterine placental perfusion VLBW babies, especially in the babies who undergo cesarean section. No, so like. It's even in the, if you read the fine print, it went on to even suggest that that is better than the current practice. So like what would be your comment on that? And then have you tried this maneuver?
Yeah, so actually it was the last slides that I took away from my presentation, because I really think it's an interesting part, and that is, we can put it simple, is the thought of taking out the placenta and keeping it still the cord intact, so you will have the placental transfusion but without any perfusion, you could say then. So, and they had they had higher oxygen content and better saturation and so on, and that was a really interesting study. Still, the cord clamping time for the delayed clamp was very short. I don't know if it was 30 seconds or 1 minute, but it was not the timing of delayed cord clamping that I would call delayed cord clamping. But still, I think a lot of people like milking, that would be so easy at cesarean sections for the obstetrician to just take out the placenta and take it away with the baby. And I'm happy to say that I'm a co-supervisor to a midwife in Norway, in our sibling country, that is performing a study right now on that also. And so we will be able to compare how resuscitation by that is how that is behaves. So I'm sure by this very interesting German study, more people will be interested in doing this research. And I would say that's perhaps the most important message today, is that when you do intact cord resuscitation, you decide to do that on preterms or terms, you really should have good documentation, because the society, the global society, still needs all these data. And we shouldn't do the same mistake as for hypothermia, where we thought that one temperature is the same for all infants all around the world, which we had to realize that perhaps it's not the same solution in different parts of the world for hypothermia. I think it's the same with delayed cord clamping or sustained cord circulation. Still, my feelings, not my so this is not based on any research. Still, I want in my research the placenta to help the baby. I want the placenta to be attached to the uterus, because it still can help the baby. It's like it's not a heart-lung machine, but it's a lung machine. If the baby heart is working, the placenta will help the baby to gain more oxygen, and actually also higher sugar content or glucose content, of course.
Great. Thank you so much. And probably, like we would await your what is the results of the babies who are being done in Norway under your supervision.
Yeah, well, you are welcome to wait, but there is such a wonderful opportunities in so many countries that has much larger delivery departments than we have. We are small countries with delivery departments that are very small compared to a lot of the very nice units that I've been visiting in Asia or in Africa, for that case. So I think the collaboration of that we did in Nepal was very successful, and I really think that we should find ways to learn and to get results together. So I hope we will see a lot of initiatives from all around the world. But I think the main part is to make it very strict in a scientific sense, and it's difficult because it takes a lot of experience to do that.
Thank
Professor
you.
Ola,
Professor.
before we finish today, I have another 2 questions for you. So first is that, like, we are doing delayed cord clamping for so many years now. So is there any changes in the NRP guideline pre-dactyl saturation, what we see, that 1 minute to 5 to 10 minutes? Is there any review on that?
No, I
Changes?
know that Maxim Vento and other people, they are working on doing this, but I think actually we are looking forward very, very much to also a Norwegian study where they look at delayed cord clamping, and they also wait 6 minutes or more in Norway now, and they have I think it's several thousand of babies now that they are recording. Both this is by the Lærdal the groups that are tied to Lærdal in Stavanger. They will have a lot of saturation data and heart rate data. There is some studies, there is a lot of publications now, but they are pointing in little different directions. So I hope we will have that, but they are not there yet.
And so what is your take on this delayed cord clamping and the stem cell banking? So sometimes we are faced with that in the operation theater, that, so how to handle the situation?
Yeah. So this is a very ethical and difficult question, of course, and I think that the American Association of Obstetrician and Gynecologists, they have a paper from 2020 that has a very good discussion on this, where they can show that if you decide to gather or harvest stem cells, it's less than half of the times that it's really you will get enough stem cells to be able to use it. And then for the individual baby, it's somewhere between one out of 5,000 or 1 up to 200,000 that will really have any help of it. So if you do it privately, it's really a very, very high cost to get this kind of insurance, or what you would say. But so what they say that is, if it's like in a situation where it comes to saving a sibling's life, or where you really have a very, very not abstract, but the other way around. Something here we are really helping one person directly by doing a stem cell harvesting. They say that is something they could encourage, but otherwise there is not any circumstances actually where you could encourage stem cell banking. And it's like we haven't started thinking about the baby's blood as its own blood, because you think, well, it doesn't hurt and the baby won't protest. But if you would ask the parents that, okay, if you took the end of your ear, if that would be possible to make stem cells, if you just cut the ear here, the baby would be screaming for 5 seconds, but then it will be over. And then you could freeze that, and that would perhaps save its baby's life in 20 years. No parent would say that would be okay. So I think that's sort of, we have to start acknowledge that this is the baby's organ, as a finger or the tip of the ear is, or whatever. So we are actually taking away something that is we shouldn't be allowed to do without having very high explanations on why doing it. That's my personal take on it, but I can also absolutely refer to the discussion from the ACOG That is, I think it was 2020 that this was published.
And so my last question, you already discussed about that umbilical cord blood gas analysis. So for a baby, how it, if you do 3 minutes of delayed cord clamping, so how it affects, and if my baby needs resuscitation, I'm doing with an intact cord resuscitation, how it affects in that situation?
Yeah, we do it in the pulsating cord. So I've published a paper review. It's all I publish every paper in open access. I could say that. So and there was another Swedish paper in Sweden. We have done umbilical cord blood, the blood gas sampling in pulsating cords for 20 years. So I was really surprised to realize that people don't do that in the rest of the world, actually, because so 15 to 30 seconds after the baby is born, while it's in the mother's lap, the midwife or an assistant nurse takes the blood gases. In the cesarean sections, it's either the midwife, an assistant, or the obstetrician himself that takes the blood gases while the cord is intact. And so that's my answer.
So it doesn't affect, it's correct, like whatever we
Yeah.
are saying.
Yeah.
Done. Thank you.
Because of course you don't want to wait 3 minutes to take a blood gas, even if there is studies showing that it's not so large differences. But of course that's you want to have a blood gas that is taken as soon as possible after the baby is born, and you want to compare the vein and the artery. That's really the most important thing for us, I think, for the neonatologists.
Thank you. Thank you, sir.
So before we close, first of all, I would like to thank both the moderators, Dr. Suchita Joshi and Dr. Tanushri Mukherjee, for conducting an extensive discussion on this topic. And thank you so much, Professor Andersson. It was a wonderful talk. Actually, in fact, this is the third in session in our Learn from the Legend series. The first one was by, as I was mentioning you the other day, Professor Zubaira Guy, second one by Professor Anup Katari, and today. So every time we learn something as we go along. That's wonderful. Looking forward to, as we were discussing the other day, more discussions and collaborations, especially when you visit us in December for our national conference. So
thank you very
so
much for the invitation.
Thank you. Now, before I close, we have the Secretary General of NNF, Dr. Surender Bisht. Dr. Surender, would you like to speak a few words?
He is muted.
Please unmute your yeah. You have to yeah.
Hi, can you hear me?
Yes, please go ahead.
Thank you, Professor Ola. On behalf of National Neonatology Forum, I extend all my gratitude and thanks to you. In fact, last year when we started our next series, Neonatal Expert Talks, it was started with the talk by Anup Kathuria, and we were so glad that again we are having a similar talk in this thing. And the kind of emotional and you can say ethical and moral last word you said was so good about that 2 tablespoons of blood which comes there, and it is the baby's blood which no parent should give up to anybody. So that kind of an air lobule analogy I'm certainly going to use anywhere now in future. Actually mentioning your name all the time. Thank you, Dr. Suchita. I'm so glad Manoj and Dr. Arun Nyopain for bringing Dr. Suchita here. She's a family to me, and I'm so glad that my family from Nepal could participate here. Thank you, Suchita. Dr. Tanushri, glad to see you. I think I've talked to you before, but I have not seen you. And thank you, Manoj, for actually letting me look at Dr. Tanushri. And we really want to do more collaboration as part of NNF and other regions. Dr. Ola, as Dr. Manoj rightly said, in the coming years, he's the leader of the National Neurology Forum and the neurology community of India, we would like to see more of these kind of collaboration, association, research, exchange of ideas and exchange of, in fact, these kind of events together. And I think that is going to happen. Thank you, Manoj, for doing all that. Thank you all.
So with all and finally, before we close, let me thank all of you, the respected attendees who have been with us for the last 4 years. I can see half or two-thirds have already left, but then still under absence, let me thank all of you for being with us for all the sessions. Again, inviting you, please do join after 2 weeks. This time, since we are not having a session in April, we are having a session after 2 weeks. That's going to be by Professor Joseph Candy. In fact, if you remember, last year we had the second talk on sepsis after the first original talk in 2020. Last year we had a talk by Professor William Bennett, one of the great legends of neonatology from US. Now, he was mentioning about this great researcher, young researcher, Professor Joseph Candy from Texas. Now, he's going to talk to us about neonatal sepsis after 2 weeks. So please do join us for that. And once again, let me thank the legend of the day, Professor Ola Andersson, for joining us. Thank you, all of you. Have a great day.
Thank you. Thank you.
Thank you, everyone.
Thank you.
Thank
Good
you.
night. Thank you.